So as we get into the different systems, we'll start to see general categories of pathologies, and one of them is always infectious. So we have infectious pathologies for almost everything. So we're going to talk about infectious diseases of the integumentary system and common skin infections and what we're going to do about it. So the classification of integumentary infections, fungal, viral, bacterial, or parasitic. The fungal is the ringworm. And so a lot of things that we call athlete's foot, jock itch, nail fungus, those are all kind of those same fungal diseases. Viral include herpes simplex, cold sores, shingles, which is from varicella zoster, which is the same thing that causes chickenpox. Warts are from the human papillomavirus, and they're same thing that causes cervical and head and neck cancer. So just different forms of the virus can cause different types of diseases. Bacterial infections are often from opportunistic pathogens from our normal flora. Impetigo, cellulitis, and MRSA infections are common bacterial infections. Parasitic infections include scabies, yuck, and lice. Like that's the worst type of skin infection. Well, I don't know about that, but it's the creepiest maybe. Universal risk factors for all infections, compromised immunity. If you have compromised immunity, you are definitely more susceptible. Poor hygiene, close contact environments, shared equipment, and moisture and warmth. So we talk a lot about MRSA infections and other and athlete's foot, that sort of thing, in close contact sports, shared equipment in sports like wrestling mats that don't get wiped down between every mat, moisture and warmth, that's, it's all right there. So fungal infections are the key characteristic is a ring-shaped lesion with central clearing. So that's why they call it ringworm. It's not actually a worm. And the symptoms are itching, scaling, burning, located in the feet, groin, body, scalp, or nails. And the different type depends on where it's located. So if it's Tinea is the fungus. Tinea pedis is athlete's foot, located in the feet. Tinea cruris is jock itch, located in the groin. Tinea corporis is anywhere else on the body. Ringworm is what they call it, but it's all the same organism. So it's transmitted through direct contact and contaminated surfaces. So we want to avoid direct contact, use barrier protection. So you're going to use gloves and whatnot. Recommend antifungal treatment, emphasize hygiene, and keeping the area dry. So viral infections include herpes simplex and varicella zoster, which causes chickenpox and shingles. There are different types of herpes simplex viruses. HSV1 is the oral, cold sores and fever blisters. HSV2 is genital herpes. There are some risks of herpes. That's herpetic whitlow is one of them. It's your finger gets infected. Transmission is through direct contact with lesions. So if somebody has an active cold sore, that's when it can be transmitted. The course is usually recurrent with 7 to 10 day episodes. For shingles, once you have chickenpox, the chickenpox virus lives in your nerves and it's reactivated later in life. Usually presents as a unilateral dermatomal distribution, and the symptoms are severe pain and a vesicular rash, meaning the rash has vesicles, so blisters with fluid-filled blisters. Risk factors including being older than 50 or being immunocompromised, and a complication of shingles could be post-herpetic neuralgia. There is a vaccine for chickenpox and for shingles now. And there's an antiviral treatment for shingles that you have to start within 72 hours for effectiveness. And the active lesions can transmit the virus to non-immune individuals. So someone that hasn't had chickenpox. And so the thing about shingles is you don't always, a lot of people, they have the pain before it breaks out into a rash. So they don't know it's shingles until after 72 hours. And so the antiviral treatment can't be used a lot of times because it's been too long. The vaccine, however, you could get that ahead of time. And it's a good idea. So it's the varicella zoster virus causes chickenpox and then remains dormant in the nerve roots and can reactivate years later as shingles. The vesicle eruption is usually the thing that makes you go, "Oh, it's shingles. I'm not just having back pain." So there can be some pretty serious complications if other areas are infected, but they're not as common. There is a risk of transmission with active vesicles. So that's something you really want to be concerned about. One time I was working with someone in the clinic and they had back pain. They went to their doctor for back pain and they got a referral to PT. And I don't think this would happen these days, but she got right in. Now you have like a 6 week wait, but she got right in. And so the PT evaluated her the day after she was in the doctor, and it still hadn't erupted yet. So it just looked like some redness. And the patient said, "Well, I have been putting a heating pad on it." And the PT thought the redness was from the heating pad. So then by the time 3 days later, when she saw me, the PT had put in the plan of care manual therapy for to relax the muscle spasm. And by that time, the vesicles had erupted. And so I brought the PT right in and said, "Hey, I think this is shingles from the pattern and whatever." And she goes, "Sure enough, look at that. It didn't look like that when she was in for her evaluation." And so I was the one that caught it, and we sent her right back to her doctor and because it had been within 72 hours, she was able to do the antiviral. So early detection is really important. Vaccination would be even better. So advancing age is a major factor, and a lot of our patients are older people. If someone's immunocompromised or on immunosuppressive medications for anything like rheumatoid arthritis or ankylosing spondylitis, that they could be at more of a risk for shingles. There's a higher prevalence in women and Caucasians. So if you're a Caucasian woman, you have the double whammy, I guess. So you want to avoid direct contact with active vesicles, use standard precautions, be aware of dermatomal pain patterns. That's a really big clue for shingles. It's in a dermatomal pattern. Um, the post-herpetic neuropathy may cause pain that affects function later on. You want to be gentle handling the affected areas, and the shingle vaccine is recommended for everyone over 50. So if you're over 50, get it. If you're under 50, plan to get it after you turn 50. Um, Herpes zoster presents along dermatomes and may cause long-term pain. It doesn't always, but it may. Most people only have shingles once, but some people have it more than once. So a bummer. Bacterial infections, impetigo's bacterial, the usual cause is staph or strep bacteria, so our normal flora. The appearance is a honey-crusted lesion. Located on the face, arms, and legs. Children are at high risk, and close contact with people at high risk. The treatment is topical or oral antibiotics, and they're highly contagious. And they require treatment of all close contacts to prevent reinfection. So little kids will put things in their mouth. That's part of how they explore the world, and they'll share things that they put in their mouth. And so if you're say your kid goes to daycare and they start to have this bacterial infection, you need to keep them home and until they're cured of it. So it's bacterial skin infection, most common in children, usually affects face, arms, and legs, and there's that yellowish crust and blisters that may be painful and itchy. That's hard with little kids because they'll just itch and that helps spread it. So we don't want to do that. It's highly contagious and it spreads through schools and daycares like wildfire because of close contact and shared objects. And there are antibiotic resistant forms of the bacteria that cause this, so that's trouble. They're often treated with topical antibiotic creams or oral antibiotics. Proper hygiene, hand washing. We want to have strict hygiene protocols, limit their treatment until it's resolved, and disinfect every piece of equipment you can find. Educate the patient and family to disinfect their whole environment and monitor for complications. So cellulitis is sometimes called erythropelos, although you'll hear cellulitis much more commonly. It's an infection of the dermis and the subcutaneous tissue, so the dermis and the hypodermis, usually secondary to an injury. It may be iatrogenic, so caused by some other medical treatment. The causative organism is usually Staphylococcus aureus or sometimes Streptococcus, so there are normal flora. It's frequently in the lower trunk and legs, especially in individuals with restricted circulation in the extremities. So people with peripheral artery disease and diabetic metabolic issues are more at risk for cellulitis. The area becomes red, swollen, and painful, and red streaks may develop running along the lymph vessels proximal to the infected area. And it's treated with antibiotics. And a lot of times people have to be hospitalized and have IV antibiotics because there are antibiotic resistant forms of the bacteria that cause cellulitis. And it can become life-threatening. It can develop into sepsis. So boils are the medical name for them is furuncles, which totally sounds like 14th century to me, like Geoffrey Chaucer. But that's a real name. I'm not making it up. Usually caused by Staphylococcus aureus, one of our normal flora, begins at hair follicles, face, neck, and back, frequently drains large amounts of purulent exudate. Nice, right? Autoinoculation, so squeezing boils can result of spread of infection to other areas of the skin. Carbuncles, which is another 14th century word, is a collection of furuncles that coalesce to form a large infected mass. And it's usually treated by NSAIDs and cold therapy, so like ice packs for the pain. And if necessary, they sometimes open it and drain it. They don't like to do that because then you break the outer layer. And if it comes to it, sometimes antibiotics. Parasitic infections are the microscopic mites or lice that are transmitted from direct contact and shared items. The key symptom with both is severe itching. It's worse at night for scabies, which the treatment is specific anti-parasitic medications, and they're highly contagious. And usually the person has to be isolated, and you're wearing isolation gear. It requires treatment of all close contacts to prevent reinfection. So parasitic infections are no fun. Lice, as you know, spreads easily with school children. Mm. So infection control principles, we always want to use standard precautions. Always, always, every patient. One of the things I noticed during COVID is in healthcare, we always think of standard precautions as assume that all patients are infected, but we don't think about our coworkers. You have to assume that everybody is infected. Well, that was a real paradigm shift during COVID. I think that was a hard transition. But hand hygiene before and after patient contact, appropriate PPE use, safe equipment handling, environmental cleaning, and proper waste disposal. Super important. When you need contact precautions, gown and gloves for direct contact, enhanced cleaning protocols, and patient isolation considerations, depending the setting that you're in. If you have a draining or open wound or lesion, use contact precautions. If you suspect parasitic infections like scabies or lice, or it's confirmed, full-on contact precautions. Active herpes lesions, full-on contact precautions. Extensive impetigo because it's so infectious. And shingles with open and weeping vesicles. You should have gown and gloves on. So the medical referral criteria for shingles, it's a pretty urgent to refer as soon as possible because you have that 72-hour window for antiviral effectiveness. Early treatment reduces the severity and the risk of post-herpetic neuralgia, which is that pain syndrome. So refer immediately. Don't delay. Don't say, oh, you might want to go to your doctor sometime. Say, go today and call the doctor's office. So general referral guidelines, if you have a new or undiagnosed skin lesion, if the treatment isn't working and the lesion's getting worse, certain diagnoses, like the really highly infected ones or shingles that have a smaller window, or if the patient has concerns or questions, that's a great time to refer them back to their doctor or to the appropriate doctor. So the essential points for PTA practice: recognizing the common presentations and distributions of different infections. Safety first. Appropriate infection control measures are so important for skin infections. Timing is important. Early treatment is especially for shingles, but the earlier you can treat it, the less it's going to spread. So that's a good thing. You want to adapt techniques to prevent transmission. So instead of, maybe it's someone that you're usually in the gym with, and you take them into a private treatment room and then make sure everything's wiped down afterwards. You want to document thoroughly any changes in the lesions, any precautions, and the patient's response. And when in doubt, refer. It's better safe than sorry. If you're not sure if it's shingles, refer them to somebody who will be sure. So this is the little fungal infection chart, and that's what a ringworm fungus looks like. Peruse at your leisure. For risk factors, we want to do universal precautions, and hand hygiene is really important, and avoiding shared towels and equipment, and patient education on hygiene. So with fungal infections, a lot of times it happens in a shared athletic environment, and so we want to avoid that. Herpes simplex and parasitic infections, there's some specific risk factors, and if you want to review these slides, you can, but I'm not going to go over them in detail. So the slides are there for you, and it's all fun.